be of benefit to all the people.
Yes, sir, definitely. Because nowadays it's very mandatory to, have a research and publications to grow yourself, and also for all the postgraduate students,
That's
from
true.
also from their point of view of their examinations and all.
That's true,
And
ma'am.
it will be definitely they will have a more different ideas regarding many different aspects of for research.
That's true, ma'am. There's so much thing that can be done in research, and just not only bring new science, but it also makes you more popular. So,
Yes, sir.
so that's
Yes.
one of the way of getting globally popular.
Yes. So I think what is our timing is, I think 6:30. We can, if people are
We can
joined, we can start.
we can
Madam, we'll
wait
wait
for two,
for
three
5 8
minutes more.
minutes.
2 3 minutes.
3 4
Okay.
minutes.
No, no issue.
Okay.
How are you, Chaya?
I'm good. All good.
Yeah.
Just came from the hospital half an hour before, got freshen up, and then
Yes,
uh,
yes. Yeah.
I also told to all my even my colleagues, and also we have one research department head, Dr. Tripathi sir.
Hmm.
So today was our actually college council meeting. So I told him that, sir, we are having our ISA chief editor sir, who is going to enlighten us regarding research. So he told me that he will be also wants to join for this, and he will share the link to others also. So it will be benefited to all other also, not only the anesthesia persons, but
That's
also other faculties from other departments.
wonderful.
Yeah.
Yes. Yes, even I have spread it in Spain in critical care and whichever possible, even all ISA and our
Yeah, yeah.
SAMS group.
It is
So
useful
let's
for
hope.
other
Yes,
fraternity
absolutely.
also.
Other branches also, because it's
Yeah, yeah.
general.
Yeah,
It's a
it's
general one
important
thing.
to know
Anybody.
everyone.
Absolutely.
And
We
sir,
do a lot of
Rakesh
cases,
sir,
but
we as a freelance, we are little away from this
absolutely.
research and publications.
Yeah,
So
I
maybe
That's
always
what
these
I was
few
about to
people,
say.
yeah.
I
So
always say,
like, and ISA Pimpri Chinchwad is mostly freelance people. But Chaya now is taking tremendous efforts to, and even Bhavesh and Dr. Uma also. So we can have publications or maybe research methods, like we should
Hello.
that
we
should be
should
done because
involve ourselves basically.
60% of healthcare, 60-70% of healthcare is coming from corporate and freelancers in India. So
Yeah.
this means 70% of cases are being done by them. So it becomes important that they should also publish it simultaneously.
Yes, yes, absolutely. But what
Absolutely.
happens now? There are so much data to collect and legal formalities. So we remain away from these publications and writing it as a article. Even I have done many cases, but still I'm like, uh, I keep myself, कौन करेगा इतना?
But there
That
are
is
many
why
fine
you
prints actually, manuscripts, and there are formats. So उसके अंदर जाने के अंदर ऐसा लगता है छोड़ो
Yeah,
ना,
and
we are
ethical
all so busy
committee
with this.
approvals.
permission,
That is
So
approvals.
mandatory. That is
That is
mandatory.
mandatory. That's what.
mandatory.
It is as simple as
Scientific committee approval and ethical, that
Ethical
has to
committee
be
approval.
done.
that is as simple as when you go to get your driving license or when you want to buy a new car. Same process. You have to apply papers. They will give you the registration paper, and then you have to apply. So I think
Right,
it's
right.
the same process. Just we have to
Same
take one
process. Yes.
step. I think subsequent things
Yes,
are not difficult.
yeah, yeah, correct, correct. I think we can start now. It's 6:35.
Okay. So
Hmm.
on behalf of Society of Anesthesiologists, I would like to welcome Dr. Rakesh Gar, our guest speaker and he is IJ editor also in chief. So for this session, we are going to have moderator Dr. Bhavini Shah, madam. She will take over, and chairperson Dr. Chaya Suryavanshi. So I request Dr. Bhavini Shah, madam, to start the proceedings. Thank you.
Good evening, everyone. Am I audible, Bhavesh?
Yes, madam, you are very much audible. You can go ahead.
Good evening, everyone. Welcome to today's session, Prologue to Epilogue, the Power of Pain. Every research journey tells a story. From the first spark of an idea, the prologue, to the final published paper, the epilogue. It is the power of pain that decides how our work is remembered. In our clinical practice of anesthesia, we often encountered many unique and interesting cases. Yet most of the time, these experiences stay only with us. We either forget them or we are unsure how to write and share them with the world. That is exactly what today's session is about, learning how to turn our everyday clinical experiences into well-written papers that can inform, inspire, and contribute to the larger medical community. It is my privilege to welcome Dr. Rakesh Garg sir, Editor-in-Chief of Indian Journal of Anesthesia and Professor at AIIMS, New Delhi. Dr. Garg sir has over 350 national and international publications, 25 book chapters, and edited 2 textbooks. His expertise covers oncoanesthesia, airway, research, cancer pain, and palliative medicine. He is an eminent academician, a vibrant mentor, and an inspiration to young researchers across the country. We are truly honored to have him with us today. I would also like to welcome our chairperson for the session, Dr. Chaya Suryavanshi Madam, Professor and Head of the Department of Anesthesia, Dr. D.Y. Patil Medical College, Pimpri. She has more than 30 years of teaching experience and more than 40 national and international publications. She is well known for her dedication to teaching and clinical excellence. So before we begin, just a quick reminder that please keep yourself muted during the session, and we will have question answer at the end of session. So kindly hold your questions until then. Now I invite Dr. Rakesh Garg sir to deliver his talk. Sir, the screen is yours.
Thank you so much. Thank you, Madam Dr. Bhavani Shah, for the kind words, and Dr. Bhavani Seth for organizing this interaction and interact with the all the city members of SAPSI, and thank you, SAPSI, for inviting and giving this chance to me, the whole office bearers of SAPSI, and the SAMS also, the state branch, is organizing these type of academic meetings so that we can learn from each other. Thank you, each one of you, Chaya Madam, Maya Madam, and everybody, these senior members. And when we talk about the research, we were just discussing the research aspect. So when we say the research, the understanding becomes important. The research at times is not only for doing research, but it is equally important to understand research to change our clinical practice. And when we do our clinical practice, we are already doing many cases. And why not to put them into a piece of paper? And that's the power of pen. And then it becomes a publication. So it's nothing a rocket science, it's a simple science. It requires simple language, just requires a basic understanding and basic mentorship to start with. The research is basically when we advance into the era. Say, for example, if we talk about our personal life, I think everybody is keeping the latest mobile phone, smartphone, and we are aware of that when was i15 release and i16 release and when the next series are coming up. Similarly, when new vehicles come, we know that this is having a special function which can be a cruise mode in the newer vehicles and so forth. And we are able to adapt themselves to new things. And that is what the research is, because the medical science always improves, changes, many new things comes up, new molecules comes up, new techniques comes up. And this is what needs to be communicated and shared so that all clinicians across the world can follow them up and provide the best possible care. So research is primarily a modality of communicating and share knowledge, because when we share them up, it becomes important to update our clinical practice. I'm sure many of you must not be using halothane or ether nowadays. Somebody said that the isoflurane is good, so we shifted it to it. Now somebody says that sevoflurane is good, we shifted. Now people say that probably Tiva is also good, so we are using Tiva, TCI, and other regional blocks. So this is where the science is being identified through this publication, where a group of researchers have identified those issues, and they have tried to bring it to the society that this change would be better for our care. We understand that when we were using halothane around 20 years back, the recovery was a little slow. It used to take 5-10 minutes. Secretions were there, glycopyrrolate, sore throat, and all those things there. When we shifted to Tiva, TCI, or sevoflurane, dasflurane, these things were not there. So that's why we need to identify. But equally important is we want to change our clinical practice. Though we may not be the researcher, but we want to change the clinical practice. Now, when you go to the market for purchasing something, maybe you just want to go and want to buy fruits and vegetables from the market. I'm sure that you will not pick all the fruits and vegetables that come for the first time. Even in a special shop, if there are so many, say, oranges or apples lying, probably we'll try to pick some of them. So simple question is that why have you picked those? Why not everything? Because we know that everything is not good. Some apples may not be good, some may be good, so you want to buy the best, and that's why you choose them. Same thing is for research also. Anything and everything can be published in some format on the Google. Google is like a garbage bin. Anybody can post anything there. Now we do not know which is good apple, which is bad apple, which is good research, which is bad research, until we know how to check them out. And this becomes important, and hence it's not for researchers, but for clinicians also to understand that which is good research, which is bad research. They should not change their clinical practice based on a bad research. Hence, they need to identify, or this is called as critical appraisal of the published paper to check whether they want to change their clinical practice or not. So that's why I usually say that research is just not for, or research understanding is just not for researchers, but it is for everybody who is practicing clinically. For researchers, yes, there are many advantages that we do. And the other aspect is the medical legal concerns. Each one of you have been hearing many aspects. When something goes wrong, the case is being scrutinized. It is in the legal court. They will ask many things, whether you have used the standard of care, whether this is an acceptable care. They will call the experts and they will ask that whether this is evidence-based practice or not. Science changes, our personal life changes, and the research also changes. And that's why the medical legal concerns also happens. Hence, it becomes important to understand that good research, and that's why the knowledge becomes important for each one of us who is practicing clinically. And when we talk, this is a common buzzword called evidence-based medicine. This is what we use nowadays, and everybody needs to understand that it is based on evidence, the research that we are having. Now, how to choose for a search, or if you want to do a research, or if you want to change your clinical practice, whatever way it is. When you're practicing something, sometimes you realize that why patients are taking 5 minutes or 10 minutes after the case is over to become fully conscious and get them extubated. You don't want to waste those 10 minutes. Or why your patient is having pain in spite you have given a good amount of intravenous opiates. Why your patient is drowsy even after giving regional block. Why your patient is having nausea, vomiting in spite you have given them ondansetron or Paranol. Now this is what a clinical problem that you face in your clinical practice. Maybe sometimes limitations. If you're working in a daycare center, you want that patient should be discharged within 1 to 2 hours after the surgery is over if you're working in a daycare center. If the patient remains unconscious, delayed extubation, or drowsy after extubation, You need to think of that this is a clinical problem. We cannot keep for 4 hours into a daycare patient day clinic. What needs to be done? And this is where the quest for search starts. Either you do a research that why this is happening to you, or you search a published paper, a relevant publication that will identify that probably you need to change this technique. And this is what research becomes important. And when you search for a relevant publication, you also need to identify that this publication is suitable for you. Now, this is as simple as that. If you go to the countries where the temperature is -70, the clothings are different. If you come to northern India, probably the temperature or the climate is different. So this means the requirement is different. And same is for the research also. Same is for clinical practice also. The thing which is being followed at, say, other country may not be same to my patient population. Hence, the understanding of research becomes important, whether that finding is applicable to my patient or not. So again, I say that even for a clinician, this becomes important that doing research and understanding research have the same principles, and hence we need to understand them. Once you identify a clinical question, you try to answer those research questions. And when you start answering them, whether you are a clinician or whether you're a researcher conducting this, it is important that you need to understand the research process. If the research process is not followed, if the research process is not good, even for clinician, they need to understand that this study is not good. This study is not valid, and hence I will not change my clinical practice based on this. So that's why whether somebody is a freelancer or a corporate hospital practitioner or a solo practitioner or a team practitioner or working in a medical college, so this sets the basic aspect that everybody should understand that what good research is. This is as simple as that if we go to a market and buy something, unless we know what to see into this, we will not be able to buy the best. Same is for academics and clinical practice. If I want to change my practice, if I do not know which is the best research, how can I change my practice to best level? So that understanding is almost similar for clinician who is practicing clinically or for a researcher who wants to do a research. So having this background, we need to understand that, yes, the research understanding should be there for each one of us. Now, this research, or you want to do research, this should be finally published. So when we do a publication, basically, we can broadly divide it into 4 steps. One is you plan a research. Here I'll come a little later that during planning, what needs to be done. You execute the research, you do it, write, and submit and publish. So this is broadly 4 steps that we talk of. And this is how your research, once you plan it, it goes something like this. You do a review of literature, you formulate a research question, you select an appropriate research design, do the study and collect the data, interpret, analyze your findings, and publish it. So this is a research process where each step has some importance which we need to understand and follow them up. So I touch the important aspect for each research process so that we can do it. And not only the research process, even the publication process. If you submit an article to Indian Journal of Anesthesia, somebody thinks that it's a very complicated process. It takes so many different aspects. Again, I'll just show you that how IJ works, and it is very simple and it is very unbiased and it benefits authors how to do it. So once you write a paper, it needs to be submitted to the online submission of IJ. There is a detailed called instruction to authors where you follow those instructions. And once following those instructions, you can easily submit online. So there is no paperwork. Now it's absolutely paperless. Everything is online. Once you send it to it, it is received by me. And then I see that whether it adheres to the journal requirement. I was just looking for a paper just now. 15 minutes back, I received a paper which was not related to anesthesia. It was related to something about the different specialty of medical science. So this means it was not into the scope of the journal. So that's why it was rejected. Not that the article was bad, but it was not in the scope. So this is what we do check. But then since it's an anesthesiology, class. So any article which is related to anesthesiology, critical care, pain medicine, perioperative medicine will come into scope. So if it is yes, then it goes for the further review. Usually we send it to the reviewers, which will give some remarks. Based on this, we will ask some revision from the authors or take a decision. Now, this is a review process wherein the reviewers does not know who has submitted the paper. They just give the constructive inputs, which helps to take a decision. And this decision can be anything, like it could be rejection, revision, or acceptance. Rejection reason are usually wherein I will come little later in detail, where either the novelty is not there or the method is not strong. So these are two important reasons for rejection. So when I said planning of the study, during the planning, these 2 points should be taken very seriously, because once the study is done, you can't do anything with novelty, you can't do anything with method section. So that's why it becomes important. If you do the right, probably the chances of acceptance are much better. Now, the success story of publication is nothing rocket science again. So when any author submitted a paper to any of the journal across the world, probably the editors will look two important aspects. One, whether there is something new. And there is something new, why it should be published again, because it is already a known fact. If somebody do a study saying that tab block reduces the opiate requirement after abdominal surgery today, it does not have any value, because there have been hundreds of studies which has been published for tab block and its modifications. So if somebody do a study and say that this is an interesting study, it's a very important study, I agree it's an important study. But everybody knows that TAP and its now even various modification has been found that it improves the analgesia and reduces the opiate requirement, patient satisfaction becomes better. Though it is a study, but it will not be published in any journal because it is a known fact. So that's why when you can, there should be something different which is not known earlier, or there's something which is, some study says this is good, some study says bad, it's not good. Then you need to take a decision that why this is not being done, and we should do a further study, a big study, to say that this is good or this is not good, and hence we can take a decision. So this is how we decide the originality or novelty, and this is important because many of the articles are rejected purely on the basis of originality. And since the study has been done, you can't do anything. So your hard work of 2 years, 1 year, 3 years goes into waste. It will not be published in good journal. And then we want that the research has been done following a very strong, robust method. Now, this is as simple as that. If somebody asks that, if somebody has to go from, say, Pimpri to Nagpur, if you tell them the correct way as Google, that after 3 kilometers go here, after 2 kilometers take a right turn, there will be something. If somebody is so descriptive, he will reach the correct destination into a correct place because he has been followed the path, track very clearly. If somebody says that go right and then left and then right and then left and you reach there, so if something is missing, right at what point of time, at what kilometers, if these things are missing in the method section, this means if the details are missing in the method section, if the objectivity is missing in the method section, probably it is not good method. It's not good method to describe anything. And hence, sometimes the study will get rejected because of this. Now, as an editor-chief, the rule of thumb is any bad research is rejected and any sensational research is always published even if badly written, because sometimes if something is so good, I will go beyond limits to help them up to refine them and write them for them also. But most of our articles will be on a gray zone, not very sensational, but not bad also. Bad in the sense they are missing things on novelty and method section. This is what I mean by bad. But they really have worked hard, but it's not suiting to that standard. So that's why this needs to be followed. And this is what, when we see the journals submissions, why we think that this article is not good. Sometimes we start using very non-scientific language. Because in common language, when we talk in the operating room, we usually talk about the language, which is our local jargon. Say, for example, we'll say that patient was anesthetized, patient was reversed. So patient is patient is not reversed. Residual neuromuscular blockade is reversed. We will say the patient is intubated. No, patient is never intubated. Trachea is intubated. We'll say patient is cannulated. Patient is never cannulated. Veins are cannulated. Right? Urethra is having Foley's catheter. While speaking in day-to-day language, and same language comes in publication. So we understand that sometimes we really get irritated if the whole manuscript is using a very layman language. So that's why it becomes that if this person is not aware of the science writing, he has not done a good review of literature. So I'm telling you the secrets behind my experience, that how you can take the paper out. In common language, we will speak like this, but when we have to write, these are small things that will improve your caliber, that will be improve your understanding of the research. And that's why this becomes important. That easily shows these are the common things that the writing style is not good. Also, we need to remember that when we want to do a research, I just showed you the cycle. Now, in this research process, these are the two things when you plan a research. If you can remember them, it will be good during the planning process itself. Research question is, what are you planning to do for your research? Now, these are two things which you remember, FINER and PICOT. Now, FINER means these are the 5 steps of the mnemonic of FINER. So when you plan a study, think yourself that whether you are including these 5 words while you are planning a research for any topic: feasibility, interesting, novel, ethical, and relevant. Novelty I have talked about. Ethical wise, sometimes we say that we use a control group. In control group, one will receive tab block, other will not receive tab block. It does not mean that control group will not receive analgesia. Even though you are not giving tab block, but other groups should also receive analgesia in some form. So that's why while you're preparing your study, planning your study, you should be very cautious about those ethical aspects, and simultaneously the approvals and registration. Now, most of the journals across the world, all good journals made it mandatory to have ethical approvals and the trial registration. Simple process, can be done very easily, but needs to be done mandatorily. The other aspect is PICOT. So when you identify the clinical problem, you need to frame into a research question. And when you frame a research question, it will have certain ingredients, which is in the form of PICOT. So when you say research question, you can simply say whether drug A is better than drug B. So in a common sense, it is okay, but it is not a good research question because PICOT is not complete. So if we say drug A is better than drug B, for whom? Which population? Adult population going laparotomy, adult patient going heart surgery, adult patient going neurosurgery, or spine surgery. So population should be defined properly. What intervention? Drug A, which route, how much volume, what concentration? Control, comparing with whom? Outcome, better in what sense? How can you say better? Better can be the side effects are less, the pain severity is less, the duration of analgesia is more, the requirement of opiate is less. So outcome can be in many aspects. And when we say less or more, you can say something less, I can say something more, because it is very subjective. Again, it has to be in objective format. Says opiate requirement. So opiate requirement should decrease from 10 milligram boluses to 5 milligrams. So this becomes objective. Or the numerical rating scale of difference of this much. So this becomes very objective. So we cannot say more pain, less pain. It has to be objectified. That is what outcome is. And similarly, the timing of measurement. At what point of time? If you say the analgesic requirement, it could be intraoperative, it could be postoperative, it could be within 24 hours, it could be beyond 24 hours. So it should be very specific. At what time are you measuring the outcome? So this should be part of your research question, and it is very important. If you do not frame it, then we can easily say the things are not clear. Even sometimes, if you say patient population, if you have included laparotomy and laparoscopy, would say laparotomy will cause more pain, laparoscopy will cause less pain. So how can you compare apple with oranges? So this study is not good. But if you have defined population that all adult patients going midline incision laparotomy for a major organ resection with age of 18 to 65 years will be included in the study. So it will become very specific. It's laparotomy, it's adult patient, midline laparotomy incision. It becomes important, and this means these patients are comparable and you have defined the population well. So these points should be taken care when you plan a study. If they are missing, later on, you will say that some of the laparoscopy surgeries, obviously small ports will have less pain, and that's why some of the patients have less pain. Now, this is what I'm talking about, the instruction to authors. So when you have written a paper, you can publish these papers based on the various instructions. Do follow them up. It's always good if you follow, otherwise the article will go back and forth unless you have taken care the requirement of the journal. Now, another aspect when you publish a paper, these are small things, but very, very important. It needs to have an abstract, as I mentioned, a detailed methodology. Method is basically like a story. So you have to say patient will be shifted to the operating room. Inside the operating room, monitors including ECG, NIBP, pulse oximeter will be attached. A 16 gauge in. So you have to tell story that if somebody is listening, he exactly knows that how the research was done, and all steps are detailed there. So this is a very important nowadays, that all method sections should be detailed, so that if anybody wants to do it, he can do exactly in the same way. So this is what, even that if you say BP will be measured, BP can be measured by sphygmomanometer, BP can be measured by non-invasive automated blood pressure, BP can be measured by invasive blood pressure. So what to use? So you have to mention which have you used. The blood pressure can be measured in sitting position, it can be measured in supine position. So you have to clear. The blood pressure will be measured in sitting position using a non-invasive blood pressure 3 times, and the mean of BP will be recorded. So this is what needs to be mentioned, not that only BP will be recorded. So these are small things, but that is what makes your paper acceptable rejection. Figures and tables should be very clear. As I showed you in the flow of the paper, if the reviewers or editors remarks, comment them appropriately, reply them. Sometimes you may not be agreeing with the reviewers' comments, but again, you have to justify why you do not agree with them. And do not copy. Plagiarism means copying the published literature, and that's very, very important. If you follow them up, chances of papers will be much higher. And which type of papers? You can look for many types of papers. These are whether you write commentaries, review articles, clinical trials or original articles, case series, letter to editors. So there are many forms with different journals published in different formats that can be done. So let's take you through brief the research article. What are the important aspects? Because this is the most common original articles we do. So when we talk about the research article and you're going them for publication, I will just mix the publication part and the planning part both simultaneously now. So any paper has 4 components when you start writing them: introduction, methods, results, and discussion. Now, introduction should be brief. It's not equivalent to thesis. All of us has done thesis where we do a very detailed review of literature. But when you publish it, you don't have to do a review of literature, extensive one, and mention it. Introduction should be brief, focused. Why do you want to do the research? And what is your objective? This is what needs to be mentioned. So what was the problem? How earlier people have done something, but they were not able to conclude. And what was the problem? And what you are going to do. That is what needs to be done with your objective. So this is a brief where you identify the need of the paper. Methods, as I mentioned, how do you did it? So complete process. It's like a story. Results, what did you find out? In results, do not mention anything extra which you have not done or not a part of method section. Whatever you plan, only those things. and then discuss your findings. Again, no review of literature. So if you find something that drug A was better than drug B, then you compare and contrast with the existing literature, preferably latest literature, not older than 5 years, preferably last 2 years. This is what needs to be done. And this is what the other sections also comes up. The title, the acknowledgement, the references. Again, the instruction are in details in the instruction to author space. You need to follow them. Now let's see a little bit of detail of these aspects so that when you plan study or you publish, they will be important. Now, when you plan a title for your publication or doing or specifying any protocol, the title should be short, specific, relevant, and descriptive. This is important because the moment somebody reads a title, it's like an advertisement. If you see any billboards, if something is written, if it's interesting, you will read further things. If the broad title is not good, probably you'll not read it. And same is applicable for your titles also. It should be brief, but the relevant information should be there. I just mentioned a little earlier about the PICOT. So those PICOT statement, population, intervention, control, outcome, should be part of your title so that people understand that what this study is about. And hence, these are usually based on the keywords. Do not try to use abbreviations or qualifiers here, but you can always put a question, but it is always good to put PICOT format for writing a title. Now, abstract usually comes the first one, but it is usually written at the last. When you have already written your full manuscript, abstract must be written very last. It should give you brief summary. It's something like if you somebody reads an abstract, you know exactly that what this study is about, what they have done, and what was the outcome, though the details are not there. So that's why it should be like a very brief sunset, what you have done. And because many people will look on the abstract only, if you see the flip books of ISA, usually they are abstracts only. So they gives an overall view of what has been done by the authors and what was the conclusion. So this is the last thing. When you have finalized the whole manuscript, then you should write your abstract so that you can understand what it's all about. When you write an abstract for research articles, again, it is structured. It has headings. Like ISA follows background and aims, methods, results, conclusion, keywords. So this should be the component of your abstract in these format, and they are usually limited by words. Some journals allows 200, some 300, ISA allows 250. So that is what needs to be done. In the abstract, do not be very vague. Mention what you have seen and summarize the outcome of your study. Do not mention anything which you have not studied, because research is a focus research. It is not the review of literature. For review of literature, we usually publish systematic reviews and meta-analysis. Original articles abstract is what you have done. Just quote those aspects only, nothing apart from this based on the review of literature. So this is what needs to be done abstract when you publish your paper. Abstract needs to be written at the last. Maintain the word limits. Focus on the results and conclude absolutely. Usually abstract does not require references, no figures or tables, and no information that you have not studied. So no extra information should be there. Now coming to the next aspect of your publication, which is introduction. Now when you write introduction, again I said it should be focused one. It's usually just half an a page to 1 page. Start with what is known and move to the unknown, and then plan what you want to do. That is your research question. So this is important. Say, for example, if you want to say that there are some concerns into clinical practice about the pain. So you say that pain management is important for these type of surgical procedures. Various blocks or techniques has been used, but they are limited by these facts. So that's why we have a newer block and we want to look for this block. So this is what only needs to be done. And then you can say that the objective for this research, as I mentioned about PICOT format. So objective of this research is comparing this block with the other block in what type of population and what you are looking for. So this is what needs to be there in the introduction that needs to be followed. So this means introduction should have a broad information which is known, that is the previous research. What is unknown, that is the need for the study and research question. and what is new here. So if something has been done, say TAB block, SAB block, ESP block for breast surgeries, everybody knows now. So there is nothing new. So how your work differs, you have to say that this is still controversial. This is not known whether this is beneficial, whether this technique or drug is better than the other is not known. And that's why you have to do a review of literature. And that's you have to highlight here that why this study is having novelty, but what the limitation of other techniques and what new we are doing here. And that is what your hypothesis and objective comes. If there are too many references in the introduction, it itself says there is no novelty, because if you write 50 references, this means there are 50 studies already there. So what's new about it? So be cautious that if you find so many references for a research question, this means the novelty is already not there. So be cautious. You should, usually we say that 4 to 6 references are more than enough for your introduction section. And that itself confirms that there are not many studies in this area. That itself says that this is a novel study and this study needs to be done. This is how, indirectly you know that novelty exists or not. If you have a clinical question, if you go on PubMed, you find 50 articles, probably no need to do a study because you already know it. If you find just 2 articles, 5 articles, they are not very clear that whether this is beneficial or not. This is the novelty. This is how you check the originality of your study. Now coming to the method section, this is again when you plan or study, again these points becomes important. Most of the time the problem is with the method section again, why this method section leads to rejection of your studies. This is the most commonest aspect. Discussion we can always change, not a big issue. But method, if wrong, if inappropriate, if missing, you cannot change it because you probably have done the study. That's why your protocol, you should spend some time to make the method section robust. Also in the method section, the most important, if I read all this slide, the basic purpose is that if somebody else wants to do the study, he can do exactly in the same way as you have done it. It should be in such a detail. That is, it is replicable. So mention everything what you have done. If you are giving a drug, mention the route, mention the time, mention the dose, mention the, say for example, iron maybe have citrate, gluconate, fumarate, many compositions of iron with different absorptions. You have to mention that which iron, intravenous or oral. So this all details must be described into the method section. Now next 2 slides are again important, which I am summarizing that what all should be there in your method section. You must mention about the study area, where it is being done. It all depends that if you are working in a, say a nephrology center, you will have more patients with who are requiring renal-based surgeries. Those who are working on onco centers, they will bring more onco surgeries, and every patient will have different requirement. So they may not be comparable. Even if you are using TAP block in an onco center, it is on cancer patients. So it may not be applicable to non-cancer patients. So that's why it becomes important to identify where you have done the study. Also, the study period needs to be disclosed because sometimes it happens that some drugs get banned, some new drugs comes up, some old drugs are not coming into the market. If you have done a study and the drug becomes banned, it's not available, then it becomes an issue, and hence the study period should be defined. Study design. Now, every research question has a study design to answer. For example, if you want to compare drug A with drug B, probably the randomized controlled trial is the best. But if you want to look for the incidence of post-operative nausea, vomiting by an anesthesia protocol, then probably the cross-sectional or prospective observation study will be good. But if you want to observe that whether open surgery versus video surgeries are better, VATs are better, laparoscopic surgery is better. Now herein you cannot say that one patient will go laparoscopy and another patient for study will go open surgery, because we know that now everybody is doing laparoscopic surgery. So in these situations, you cannot do RCT. It will be a historical control. In the past, you were doing open surgeries, took those data, and then now you're doing laparoscopic surgeries or robotic surgeries, compare with them. So this means even this selection of the study design becomes important, that whether it will be a randomized controlled trial It's an observational study. It would be a retrospective analysis. So these type of study design selection is important and hence needs to be disclosed. Study population. I mentioned in the beginning that study population should be clearly defined because pain perception of a 10-year-old child will be different from a 20-year-old adult. Probably it will also be different for a 90-year-old male. And if you are measuring the outcome as pain, they will respond differently. A 2-year-old child will not be able to use the NRS or VAS. 90-year-old adult may be in delirium. He may not be able to answer you. So that's why your study population should be clearly defined what will be included, what will be excluded. Prerequisites of study. Tools, terminologies, orientation trainings, important. Tools, terminologies means if you want to measure the blood pressure, it should be clearly defined how will you measure the blood pressure. Because we know invasive blood pressure is different from non-invasive. There are some differences. So you cannot use in some non-invasive, some invasive, and then say they are comparable. No, it has to be clearly defined. Sometimes from arterial sample, sometimes from capillary pinprick method. All three will give you different sugar readings. So if you want to measure the blood pressure, blood sugar intraoperatively, you have to define that which method will you use for blood sugar measurement, because each three readings will have difference of around 5%. So you cannot compare them. Hence, these tools should be defined very clearly so that uniformity is maintained. Then you also need to define the process of data collection. Who will collect it? If I know that this patient I have given block, this patient I have not given block, I can be biased. So if I am aware of what has been done, I can be a little biased and affect the outcomes. Hence, the planning for data collection, the blinding, this process is called blinding, how it will be done, so that the person who is collecting the data is not aware that what patient has received, and this blinding should be done appropriately. All patient has a right, their confidentiality has to be maintained, they need to be informed, their consent has to be taken. And simultaneously, as I mentioned in the beginning, the ethical clearance and trial registration is mandatory by most of the journals across the world. So do take them before you start the study. Randomization again is an important process. When you do a randomized controlled trial, this is the best study somebody can do because this will give you the exact difference between two techniques or two drugs. So this randomization is a process. When it has to be done, there are many methods. Usually nowadays we use computer-generated random number tables or random numbers and then do allocation concealment. If you are doing RCT, do follow them appropriately. The techniques, whatever you are using it. Say, for example, if you want to measure the pain scores, you have to be very clear that how will you measure the pain scores, whether using numerical rating scale, visual analog scale. If the patient is supposed intraoperatively, under anesthesia, you cannot ask VAS or NRS. So what will be a parameter for measuring pain intraoperatively? So you can say increase in 20% of blood pressure or heart rate will be an indicator of inappropriate pain control. So these type of techniques, details must be mentioned clearly when you plan a study. Now, sample size is equally important. We need to understand that we have already planned a research question, which we have discussed earlier. To answer that research question, a certain number of people needs to be studied. It cannot be arbitrary. So that's why there is a method of sample size calculation that needs to be done a priori because you will be doing randomization. And this sample size calculation shows you that this study would require 200 patients, 100 in each arm. So this sample size, how you have calculated, what is the sample size, needs to be documented, done a priori and documented when you send it for publication. Now, when you said sample size, it will require certain values. So I may not go into detail. This is a big topic. Say alpha value, power of the sample size, attrition rate or loss to follow. So broadly, when we say power, we keep 80%, alpha error, we say 5%. So this is what we accept as norm when we calculate the sample size. So once you have done the study, it comes a time for you report them into results. Now, the results should be only what you have studied. Nothing extra you need to look for. This is called consort chart for RCT. You must declare that how many patients you recruited into a study, how many patients were randomized, how many patients were follow-up, whether they were lost to follow-up or not. So this table should be there. And at this results, the understanding of your variables also becomes important because your analysis will be based on these aspects. So when we say variables, certain variables will have number. For example, age, blood pressure. Age will be say 10, 20, 30, blood pressure 130. So these are values, numerics. So these are called quantitative variables. Certain things will be qualitative variables like gender, yes or no. So these will be severity of pain score, blood groups. So these are called numbers. They don't have numbers. They are categories where they cannot have a sequence. So these type of variables are called qualitative or categorical variables. This is essential because when you understand your variables, you need to identify and use appropriate statistical test. Sometimes when you define that, for example, you have measured the blood pressure, it is 120, sometimes 140, 160. But finally, you want to do analysis to say how many patients were hypertensive, how many were normotensive or hypotensive. Now, the first value is quantitative, 130 blood pressure. But when I say hypotensive versus normotensive, the same value becomes qualitative. And different tests will be applied for looking for the statistical significance. So these things are important because if you, in the beginning, you define that you will take hypertensive blood pressure, but if you don't have a value, you will never be able to quantify them. You can only say 10 were hypertensive, 20 were normotensive. So you just have qualitative variables and different tests will be applied. So this is important for your study. Also remember that in results, do not try to put methods or discussion. You just report what you have got the data from. And remember, data and results are different things. Data is what you collect in your sheets and your Excel chart. You should not report the same. Results is you need to compile them up. You need to summarize them up into certain things like mean, median, interquartile range, standard difference, numbers, percentages. So they have to be summarized into certain things and then they become results. So data is not equivalent to results. Data is the facts that you obtained. Now results is what you need to report, you interpret, you summarize and interpret. So that's the difference. We want you to report results, not the data. Data needs to be collected. When you publish paper, it should be results. For example, if you see this two example. In first, it's a data. 20 patients, mean score was this. In control group, in study group was this. So this is just data. No comparison, no interpretation. But if you see the second statement, it becomes results. This is what the reporting of science is. The mean pain score was higher in control group than in study group, values, p-values, and nowadays it is mandated to include the confidence interval also. So this is what needs to be done. And also remember that whatever you have planned in the method section, in the same sequence, it should be in results. If your primary objective or primary outcome was pain score, it should be pain score in the results also as a primary outcome. Secondary outcome, whatever sequence, should be the same. And the first one will be the demographic. So you need to follow this same sequence. Now, these are important scientific terminology. It becomes important. Sometimes we misuse these words. Significant does not mean difference. Significant in science is only used when it's a statistically significant. In common life, we say that you are significantly looking better, you are significantly perform good. That's an English language. But when you write in a science, it should only be when the p-value is less than 0.05. Number two, statistical significance is not equivalent to clinical significance. Sometimes when you read a paper or when you do a study and publish it, say for example, p-value comes out to be 0.001. So this p-value is highly significant. But if you see the data, for example, you have compared two video laryngoscopes for tracheal intubation in a normal airway. In one group, it was 14 seconds. In second group, it was 16 seconds. And the p-value was 0.001. Now herein, this 2-second difference in a normal airway is of no clinical significance, even if the p-value was 0.001. So that's why you should not say that video laryngoscope 2 is much better than video laryngoscope 1 because p is 0.001. No, this is a wrong interpretation. Because finally it is of clinical significance, and 2-second difference in intubation 14 versus 16 seconds in a normal airway is of no significance. Hence, do not compare and summarize and conclude that all statistical significance is equivalent to clinical significance. So be very careful about these aspects. Also, you need to remember that tables and figures should be used very clearly because these are important. If you summarize your data in table figures, it looks very well, but do not duplicate between tables and figures. So you need to be very clear that, for example, if it's hemodynamics, you are following over time, a figure will be good. If you are looking for some other factors like the total opiate consumption, the incidence of nausea, vomiting, probably table will be good. So that's why you should be very clear when you write your tables and you summarize your results into those. Charts are always good when you want to have some follow-up or multiple readings, like for example, blood pressure, heart rate, numerical rating scale over time. You can always create those charts. Do not use tables when it's very small text, 1 or 2 lines. Mention them in text. But use tables when there are large number of data, you want to summarize them. So do not make separate tables for each finding. The total amount of opiate consumption, group A, group B, a table. No, it's not required. If it's just single thing, you can always mention in text. Now coming to the discussion section, again it's important. Discussion section, once you have done the study, you know that what your results are. It is not the review of literature. It is the interpretation of your finding based on the existing literature. You should not say that study X found this, study Y found this, study and we found this. No. Why the difference between your study and study X and study Y was there? Why this difference was there? It is good or bad? So this means it is basically interpreting your data on the background of existing literature to conclude something. So this is what needs to be done. And usually, if you categorize your discussion, it can be in 3 big aspects. The first paragraph, your findings of your study. Next couple of paragraphs, based on the existing literature, try to interpret them. And last paragraph, limitation of a study and conclude them. This is what needs to be done, as you can see in this chart also. So this is in brief which has been done, wherein they have tried to identify discussion, whatever they have observed. So it has to be in brief, nothing just called, say, everything which is already published, you want to copy it. Because we mentioned the references. If somebody wants to have more details about the study, they can always click on those numbers which are, we say, citation of those references can be done. So this is what should be there in discussion. First paragraph, just summarize your findings, focus on results, no new finding, whatever you have seen, interpret those things also, and interpret and supplement based on the literature published, and then put them up. Also needs to remember that since you have done your study, if you see any articles which are published in IJA, the last paragraph just before the conclusion, nowadays it's important to find the critique or limitation of your study. Because you have done it, you may have observed some new findings, some limitations. So always it's important to accept those limitations. I found that this was a small study, or this study was done in laparotomy patients, may not be applicable to laparoscopy patients. This patient may not be applicable to pregnant females. So this means whatever the limitations of your study must be disclosed in the last paragraph of the discussion section so that people can interpret appropriately. Now, this is again important when you do a study. Sometimes bias can happen to a study, and you should look for. And this explains something called validity. Now, validity means that study is valid. Validity means that study is When I say validity, there are two aspects of it. One is internal validity and second is called external validity. Internal validity means that your method section was so robust. If you repeat the same study, probably you'll get the similar results. So there was no bias. All measurements were very objective. They were blinded, properly randomized. So this is called robustness of study. And in scientific language, if this not been done, they say there is poor internal validity and hence paper gets rejected. So this you have to follow so that these type of bias does not happen. External validity means if I do a study at AIIMS, New Delhi, is the outcome equally applicable to a city in say Maharashtra or say Nasik? We do not know. So this means that the results are applicable to the other population or not. This is called external validity. And that's where we have to define. Now you remember I said you have to mention the study place where it has been done. So this explains the external validity. Sometimes study may be applicable to India, but may not be applicable to US, maybe for many reasons, because their BMI is high. India, the diabetes is more common, so their study may not be applicable to us. So these are two aspects when we talk about the validity, and that is important aspect. Now, in the conclusion of the study, you just describe what was your primary research question. Do not describe anything else. Sometimes we overflow and write so many things. Whatever was your primary research question or primary objective, that is only what you used to conclude, which you have found from the study. Now, having said that, when you see papers which has been published, if they have done so, this means that is not a good paper. So you do not have to rely on those aspects which I have just mentioned for your publication. So this is how, when you plan your study, follow those. When you read a study, see whether they have followed this or not. If not, this means that is not a good study, and probably you should not read it to change your clinical practice. References is as per author's requirement mentioned in the instruction to authors of the journal, so do follow them up and you can do it. Now, when you write a paper, your first draft is ready. Sometimes it may have certain limitations, so you should be cautious. It may have many mistakes. Even today, when I edit the papers, I read it 2-3 times. Every time I will find some spelling errors, some formatting errors, some missing things. Even as an editor-chief, when before the IJ issue is released, I read it 2-3 times so that all those mistakes can be taken care of. And every time I say that, from the paper once is submitted and finally is published, I am able to find more than 200 to 300 mistakes in a single manuscript of various types. So that's why when you write a paper, do think, write it properly, keep it for some time and then read it again. You will find that something is not clear, some mistakes are there. So do check them up. And when you submit it, do follow the instruction to authors, depending upon the titles, the labeling of the figures, the legend of the figures, the headings, and all those forms needs to be checked. Always publish your paper into a journal which is in the scope of the journal. So always check whether it is suitable or not and follow the guidelines for those papers and submit them up. Usually majority of journals are accepting online papers nowadays, so you can always go ahead and publish it online. No paperwork for majority of journals, so it is always everything is online. So this I have already told you earlier, this process will be followed and you need to just reply back if it comes to revision so that you can clarify further. And when you submit it, sometimes it happens that reviewers will give you certain remarks, which may be sometimes very beneficial, sometimes not so beneficial, sometimes is not suitable to you. But whatever it comes, try to reply them professionally, whether you accept or not. If you accept, change it. If you don't accept, mention that why you are not changing it, because the reviewers and the editors are trying to help improve your article. So if they have some queries, it becomes important to submit them after their appropriate revision. So submit it and then try to read them once more. And even if it is accepted, it will have your proofreading and then you will see in the subsequent sessions. So to summarize, when we talk about the publications, whether you are doing for the purpose of research or whether you are reading the paper for change in clinical practice, you have to follow the same parameters. Have clear-cut research question in mind, well-defined research question, a very robust method section, using more of the objective criteria for measurements, validated tools, and describe the method section in detail as much as you can. And then subsequently, you can think of writing them in a more scientific language. Don't use jargons, common languages that we speak in the OTs, but write them more scientifically. That gives you a very broad understanding and very good scientific sense of publication of these articles. Now, this is the last slide where I leave you. Now, this site is very good. You can just even take a snapshot. This is called Equator Network, www.equatornetwork.org. Very important because when you want to do a research or publish a research, these are called reporting guidelines. Say, for example, the first guideline, reporting guideline consort. Now, it will give you certain points, 25 to 30 points, that when you plan a research or publish a research, all those points must be a part of your protocol or a publication. So just follow them up during the planning process itself when you want to do a research so that you can do them effectively. You are not missing anything. Similarly, for observational studies, TROBE is the guideline. For case reports, CARE is the guideline. So you can always have a look on this website. It's a very, very informative website. Many things, how to do randomization, how to do allocation concealment, how to do blinding. Many details will be there on this website, which you can always learn. And this will make your paper better even before you start so that your paper gets published once you finish the study. So what I say is that when you want to publish a paper, it is not when you have done it. Whether paper will be published or not, it is usually decided at the time of planning itself. So plan your paper so robustly so that you can always take it forward for a successful publication if you try to follow those findings. So those were in brief, probably both will be applicable for both aspects, whether you want to do a research or whether you want to publish a research. If you can just follow these important aspects, chances of publication will be very high. If you are a clinician not doing research but want to change a clinical practice, when you see a research paper, do check all those things are there. If all those things are there, probably it's a good paper to follow. If they're missing, then probably it's not a good paper to follow. So you can just put in the garbage bin and not to follow them up. So thank you so much. And we are open for questions, if any, or any expert comments also most welcome.
Thank you so much, sir, for your insightful session. I'm sure everyone has gained valuable tips on how to transfer their clinical work into the meaningful publication. You have nicely explained each title of publication, sir. Now I'm sure many of the clinicians from PCMC will submit their work into IJSL.
Thank you so much, ma'am.
I request Dr. Chaya madam to give their expert comments on today's session. Over to you, Dr. Chaya madam.
Good evening, all of you. First of all, I would like to congratulate Rakesh sir. It was a very wonderfully and very nicely explained the research publication to all of us. And definitely this will be helpful for our postgraduate students. When they enter into the first year, they need to have a good research thesis also. And you have explained each and every points, like introduction, how to be done, and also the research methodology, how it should be, what manner means in depth, how it should be. And also each and every point is explained very well. So this will help them in future for doing the more good research and also more good thesis publication. And also, sir, I would like to congratulate you for giving us a very wonderful lecture. You have mentioned each and every aspects of research methodology, basically starting from how the paper should be helpful for our clinical practice people, means when they have problems with their clinical practice, it will really helpful for them with the research method to improve themselves. Then another thing, how you should plan your all the research, everything. Then they should not also think, means even there is a rejections in initial publication, then they should find out where is the problems. And I think this you have mentioned it very well for rejection process also. Then the rule of thumb, where you have mentioned really how much scientific language, importance of scientific language. Definitely many times we do use the language which is not correctly scientific. And also the different PICOT criteria and finer criteria was very well explained, sir. Few things we were also unaware regarding writing the research. So this was also very well mentioned from you in your lecture. And also many times, sir, statistical analysis and importance of value of significance, like p-value and all, are people are not aware about this. So that also you highlighted very well, and the importance of means not to write anything shabbily, write it in a correct manner. This was also very well explained by you, and I think it will be helpful for postgraduate students, but it will be also helpful for those other people like a clinical practitioner who are practicing and having a data, but they are not able to do the research in spite of having data. So these points will be helpful for them. Only things are they might have some problem regarding ethical committee clearance and also CTRI number. Someone I think must have put it in the chat box also. Sir, I would like to ask you one question.
Yes.
Sir, regarding any research or whichever we are doing any study, if the patient is only ASA 1 or 2, ASA grade 1 or 2 should be included, or can we have a patient who are having ASA 3 grade? Sometimes we are doing lots of kidney transplant patient or patient with CKD come for some surgeries in urological procedures. So they are not ASA 1 or 2. Then can we mention those in our research?
Right, you can include any patient. So when I say PICOT, when I say patient population, it should be described there itself at which population will you take. So for example, if you're looking for laryngoscopic response, if you say ASA3 CAD patients, so probably they will show different response as compared to a non-hypertensive normal patients of ASA1. So probably your outcome will be affected. This is called bias. So that's why when you select a study, you should see that the population should be homogeneous for the outcome that you're looking for. So that you have to define based on what your research question was, and accordingly you should select it. Similarly, I said, say pain management. If you are looking, say tab block, so you cannot compare a infant surgery with an child surgery with an adult surgery. They will have different pain sensation. They have different management, and hence you cannot compare. So we cannot compare apple with oranges, and that's why ASA1 cannot be compared with ASA3. But depending upon your objective, if you think they are not affected by ASA3, you can take it. So this is all depends upon what you have defined.
But can there be any ethical or scientific committee?
No, absolutely no, there is no ethical concerns. You have to define them. People have been doing studies in ASA3. So let's say, for example, patients who are undergoing kidney transplant, majority of them are ASA3 patient, liver transplant. All are ASA3 patients. So you are doing ASA3, but your patient population was for that only. You are doing it liver transplant patients. So there are ASA3 patients. Cardiac transplant, they may be higher ASA. So that has to be defined into your research question, and based on this, you have to select your population. But you cannot have a heterogeneous population and then compare the outcome which can be affected.
And so one more question. Is it CTRI is required for any other study like observation study? Just we are not including any drugs, anything, any trials, but only the observation study.
So
Then
basic,
do we have to have the CTRI number also?
so our basic principle, madam. If anybody as a human is involved, please take CTRI. Simple as that. No confusion. So don't get into confused whether it's RCT or observational studies. If it's a human-based studies, please take a CTRI.
Sir, there are many questions in chat box. Are the unusual case report accepted and rules for the case report publication?
There are no rules for publication. Anything which is novel, some different, some new message is accepted. Case reports are also acceptable. Here we need to understand challenging case is not equivalent to a novel case. Many of the time we do a lot of challenging cases, multiple comorbidities, but there is no novelty into it. Anything which is something different. So when you do something case, look, have you done something different? Is the patient behaved something different which has not been known earlier? Then it is a reason to publish it. Sometimes in a very interesting case of multiple comorbidity of say Treacher-Collins syndrome for airway management. I understand it's an interesting case. It's a complex case, but it is mentioned in the textbooks how to manage the Treacher-Collins has a difficult airway, and you have to follow a difficult airway algorithm. So challenging case or interesting case is not equivalent to novel case. So please differentiate between these two aspects. When you send it for publication, now there are many journals which exclusively publishes the case reports also, and even IJ also accept case reports if it's really very novel. So it's acceptable.
So Dr. Mayuresh is asking how to get ethics committee approval for doing research in less than 50 bedded hospital or nursing home.
So you have to have your research ethical committee, which you can always form. If you visit the ICMR website, how to make the ethical committee is very well mentioned. It has to be registered. If it does not have, you can contact the nearest medical college or nearest other institute which have ethical committee, and you can sign an MOU with them that your nursing home or your hospital will get ethical approval from those areas. And after the MOU signing between these two small institutes, the bigger institutes will give you an ethical approval, and then you can study. So these are two ways of doing getting the ethical approvals.
Dr. Vaibhavi is asking how should one look for the correct journal for publication?
So this all depends upon if you visit any journal website. On the journal website, there is scope of the journal. If you visit the IJ website, I have already put in the title scope of the journal. So like for IJ, we say that any article related to anesthesiology, perioperative medicine, pain medicine, and critical care medicine is acceptable. So if somebody publishes a surgery article, it will not be acceptable. So this is called scope of the journal. So all journals on their submission site or their website will share the scope of the journal. So if your article suits into scope, you can submit it there. So this is how you need to get. Usually we say that the index journals are given a priority over non-index journals. So again, on the journal website, it will be whether it's PubMed index, whether it's Scopus index, whether it's Medline index. So all those will be mentioned, and based on this, you can take a decision where to publish it.
Bhatkar madam is asking tool to look for plagiarism, and are there any publication charges for IJN?
So IJ is till now, we have not started any charges. So IJ is able to get subscriptions and advertisements. So that is bearing the cost. So till now we have tried, ISA and myself have tried not to charge any amount in any way from any of the authors at any time. So it's absolutely free. It's an open access. Even going on the journal websites, I have kept it almost free till date. So there is no charges, number one. Number two, the other question was the plagiarism. So plagiarism, there are certain tools which which are available. Some are free, some are paid. So like Authenticate, Truntin, these are paid, which gives you the similarity. And there are certain tools like soft free tools and other. If you see on Google, just see free tools. Those are also available. But the best thing is, say by heart, I know that whether it's plagiarized or not. If I copy and paste, I know it's plagiarized. So why I need to check it? This is as simple as that. If I take a white paper and type everything by hand without seeing anything, can it be plagiarized? No, it will not be plagiarized. So I think that is important, wherein you can always know whether you have copied from some source or not. So this is my suggestion for each one of you. When you write your paper, never ever try to copy and paste. This is very common in computer. You just select an article, copy and paste in a Word file. Please don't do it. You read the article, fine, you read it, and then write it in your own language, interpret in your own language, and cite it appropriately, reference it appropriately. So plagiarism issue will not happen. But yes, tools are available. So please check in case, even if there is some inadvertent plagiarism has happened. So try to check them up.
Dr. Samya and Dr. Sanjana is asking, in today's era of AI-assisted writing, any advice on how we can maintain our scientific originality?
So at this juncture, I will suggest that don't use AI for scientific writing. It's not a good tool. If you see IJ, some articles, we have published some articles and editorials. There's a lot of issues with the AI. I mentioned in the beginning in my lecture also, AI does not have a brain. AI collects data from the web. That is Google, right? It's same as Google. And we know that in Google, almost 70 to 80% things are garbage. So AI will pick the things from garbage. If something is picked from garbage, do you think it will be good? No, it will not be good. It's not that it's always picking from the certified areas, right? It's as same as if you want to buy a new mobile phone, you will show to a branded showroom. You will not to go to a chore bazaar, because you know that every inside equipment or inside the mobile, everything will be duplicate. So this is as simple as that. AI will be like a duplicate collecting material from different sources, which is not reliable. So please do not use AI. Be proud of your gray cells into your brain, and they are the most intelligent one. And AI cannot be more than intelligent than you are. So be proud of yourself and write it yourself, interpret yourself, and write it. Don't use AI as of now for doing the research or writing the research. AI is okay if you want to check for grammar, spelling mistakes, referencing. That's fine. You can check them, because all of us are not very strong in English grammar. Sometimes we may have spelling errors. So you can use Grammarly for those things, but do not use AI for writing the research completely or interpreting the results, because AI also hallucinates. AI will never say that AI does not know. You put anything, they will give you answer. I was just checking once on the literature. I say, for this statement, give me 5 references. The AI gave me 5 references. And when I try to locate those references, only 2 references existed in this word. 3 references never existed. So the AI is hallucinated, because I've asked 5, AI has to give 5. So 2 existed, 3 were non-existent, those references. So AI do a hallucination. So just go and Google AI hallucination. There is another word, AI regurgitation. It regurgitates whatever it comes to its mind. So those are not tools for framing something, for writing something, for interpreting something. Do it yourself. They can be helpful for grammar check, some amount of language check you can do for those purposes.
Sir, I want to ask one question, that publishing a paper, it is a long and tedious job, actually, and many of them lose motivation in between. So what advice would you give for them, especially publishing in IJ, sir? Sorry to say.
So before say, I will ask you one question, madam, right?
Yes, sir.
Say if we do not have a family financial support, or we do not have a big parents who has given us millions of rupees to us, we work harder, collect some money, and in lifetime we are able to purchase one big house for ourselves. That is by our money.
Yes, sir.
So how do you feel that? You say after 30 or 40 years of hard work, working solo, husband, wife, both working, it's a hard-earned money, have taken some loan and purchase your 3 BHK and 4 BHK or a duplex. How did you feel about it? Doesn't it feel so good? Do you get demotivated that after 40 years you have to purchase your own house, which you can say that it's your house, your money? Same thing is with publications, madam.
Yes, sir. I know that publishing article in IJ is a prestigious, sir. I have 2 articles in IJ published.
So it's like an addiction, madam. Once you start, people say that is hard, it's tedious. It's like an you can say your daily work. You really want to enjoy it. Sometimes when you're talking on the phone, but you can cook so nicely in the kitchen. While in the front of a kitchen, your tab is there with your cereals going on. And you're talking to a phone to your friend or to your kids or to your parents. So you never say that you are tired of cooking every day a delicious food for your kids. Are you tired for it? No. It's the way we enjoy. I remember my time when I was a postgraduate, my first paper was published, and during my senior residency, I was publishing almost one paper every 10 to 15 days, a case report, because I was working at AIMS, and it's a big place where every case is so challenging and difficult. So over almost 4 to 5 hours during my residency itself, I was able to do almost around 92 publications at that time.
Wow.
Now I have crossed more than 500 publications.
Yes,
It's
sir.
not tedious. You start enjoying it because you get a knack of it, right? Once you get a knack of it, people sometimes says that राकेश सर का जरूर कुछ एडिटर चीफ से कुछ डायरेक्ट कांटेक्ट होगा, और अब मुझे भी बोलते हैं कि उसका राकेश का से कुछ कांटेक्ट होगा इसलिए उसके पेपर छप जाते हैं. I will say इसलिए नहीं छपते because now you have become more practiced.
Yes, sir.
Right? If I ask you, everybody say what patient was reversed at the end of surgery. I said, how can you reverse the patient? Patient is lying supine only, na? It's a residual neuromuscular blockade reversed, right? So if somebody says patient was reversed, it's so annoying to me that he does not know science. So now, but when I write a paper, I will always, inherently, if somebody author submit, I will correct it. That the residual neuromuscular blockage was reversed, trachea was intubated, vein was cannulated, right? Muscle relaxant is a size here. It's not muscle relaxant, it's a neuromuscular blockade, right? If you have seen in the Salting and physiology books. So this is what, when you start writing science, when you start interpreting science, it becomes so easy for you, right? When it's become easy for you, success rate becomes better. I remember during my residency, my first paper was rejected a couple of times. So at that time, I also thought that, I asked my guide, sir, you know the editor chief, please ask him or her to publish my paper because they need contact. He said, Rakesh, if it is a good paper, they will publish it. I will not phone him. And then I always improvise, and now I can realize that even if somebody calls me to publish paper, please don't mind. If it's a good paper, it's published. I'm very unbiased nowadays. If it's a bad paper, it should not be published. If it's a great paper, I would give them a second, 3, 4, 5th revision. I'm okay with it. Even 10 revisions, I'm okay. So this is what, when we get a knack of it, it's not, and when you start enjoying it, it becomes easy. If somebody asks me to run a marathon, I will be mad because I cannot run 42 kilometers. But people who are doing marathon, they really enjoy running 42 kilometers. And even after 40, they are so happy. If you ask me to run for 2 kilometers, 3 kilometers, I feel so annoyed because I'm not running so much. So this is what, when you start
matter of passion, sir. So you have that passion basically, and the knack. So for us, it is little difficult or maybe tedious. What Bhavini has told.
If you ask me to make a oil painting or a watercolor painting, probably for next 1 week I will be so frustrated and annoyed. But if I ask Maya madam to do it, she will do 10 color painting and give me a watercolor painting by tomorrow morning because she enjoys doing it. She has a knack of it. That's
half an hour.
Deshpande sir wants to
ask
he has
something.
raised the hand. Yes, sir. Good evening, sir. Hello.
Sir, you can unmute yourself and ask.
Yeah. Good evening, sir. Good evening.
Yes, sir. No, sir, you are not audible. You unmute yourself.
Sir, unmute yourself.
I forgot to unmute.
Sir, unmute kara. Unmute kara.
Just touch the screen, you will get the pop-up of mute, unmute.
Sir, muted at both.
time, can I ask you one thing?
Yes.
Yeah, sir, what is the Q1 to Q4 index? There is a, we were asked where, in which category is your publication, and it was said you should mention Q1 to Q4. So what is that?
So this is, say, for example, across the world, approximately, I think 69 or 68 journals are published under the category of anesthesiology, in which IJ also comes. There are billions of journals. So usually they are categorized into those things, and this is primarily based on impact factor, which goes up and down. And there are many scoring systems for the looking for the journal performance. So this is one where you see the ranking of the journal comes, and they usually divide into quartiles. It's something like a percentile. And based on this, they put in Q1, Q2, Q3, Q4. Impact factor is based on the number of articles being cited in the previous 2 years in this year. It gives the impact factor. If you see the interaction in the social media, it gives by almetric score. Citation for the last 5 years comes the site score. So these are different matrices of seeing the journal articles, the quality of articles, how they are being cited. So there are multiple factors which determines these impact factor, site score, altmetric score, and quartiles. That is, you mentioned about Q1, Q2, Q3, and Q4.
Sir, Dr. Mohan Pathak sir
Thank
is
you, sir.
asking, for anesthesiologist in government service, is it necessary to get permission from their department
For what?
for publication, I think?
No. So publication, you don't need any permissions from the department as such. But if it is a case report or it is a case report, you need to take patient's consent. If it is a study, you need to take ethical approval, which is as per your institutional protocols. So those has to be taken. But just purely for the purpose of publication, a separate permission is not required anywhere across the world.
Deshpande sir want to ask something? Maya?
But
Hello.
sir is not able to.
Hello.
Yeah, good
Can
evening,
you
sir.
listen me?
Yes, sir.
Welcome.
Yes, sir.
Good evening.
Good evening,
Namaste,
sir.
Rakesh Sirji, namaste. Meeting you after a long time.
Namaste, sir. Nice to see you, sir.
I think Rakesh, you have already conducted the seminars for how to write a paper, how to do it, isn't it?
Yes, sir.
And it has been done. I remember when I was in council, we did it.
Yes, sir. It has been done
And
at various places in
what
India.
example you have given is exactly correct. You are not tired of cooking every day. And that is true. That is true.
For
It takes
Pimpri
time.
Chinchwad, it is for the first time. So we also
Yeah.
enjoyed it.
Yeah,
And
we
we have learned
understand it.
many
Yes.
things.
Yes.
Yeah.
We understand it, Maya.
Yeah.
But see, what you have to do is that you have to really put your efforts in doing a research paper. It is not
Right.
just copying from something and something. And
Yes.
what Rakesh sir has given the hints, those are really good. AI does not
Guideline.
give you everything. AI gives you all garbage. That I had also experienced it. But I would say, I would suggest to my colleagues that please take the help of AI up to limited extent only. Do not believe on AI. AI continuously do not believe on it. Absolutely not. You should not believe on it.
Absolutely.
And you have to reconfirm it. What Rakesh sir has said is correct. If you ask 5 references, that will give 5. If you ask 10, that will give 10. But as he said it correctly, that you may not get the references at all. It just gives the list. And it's not good. It's not good to be very dependent on AI. You want to do a paper, you have to exert yourself. Then only you will understand. And what Rakesh sir has said is really true. Nowadays, everything is with the technique. All exams are, there is a technique of the exam, there is a technique of writing a paper. And once your one paper will get published, you get that technique and you can have a number of papers then because you know what is to be done, how it is to be done. Rakesh sir, seeing you after a very long time,
Thank you. Thank
but
you, sir.
as fresh as you were, I had seen you, I think 5 years ago or
Thank you
so.
for your blessing.
Yes, yeah.
Thank you for your blessing, sir.
Thank you.
Sir,
No
good
blessing,
evening, sir.
No blessing.
Sir,
Yes.
good evening. Deshpande
Yeah.
sir, good evening.
Yes,
What I
yes.
am telling about, I am a person who is a data analyst. This is my second source of income. But then I said, whose English is poor? Like somebody don't know what language to use. So whose English is poor? Can they get the help of AI help to
That
write?
Rakesh sir has already said it, madam. You can use AI for grammar and good English, no
Yeah,
doubt.
yeah,
See,
yeah.
English is not
So
our first
is
language.
is that accepted? Like what I
Yeah, it is
said?
accepted. But
That's-
again, if you write the same sentences from the same author, that is not accepted.
Yeah.
There are so many
No, no.
softwares of that, isn't
Yeah,
it?
yeah, yeah. There
So
are
what I mean-
Yeah, sir has
different
already mentioned that.
tools.
Yeah,
Yeah,
yeah.
there are
So what-
different tools
There
which
are
say
tools, yes.
differently.
Yes, yes,
what
yes.
I mean is that if you have written a manuscript of your own, then you can run the AI to check that your grammar is okay and
Yeah.
language polishing can be done. Because herein it's your idea, you have written it completely. You're just
Yes.
checking for grammar and the spellings. You're
Yeah.
not asking something to write separately or differently. So
Yeah.
those are
Right.
allowed. But then you should not say that I have idea that drug A, say dexmedetomidine is a good analgesic as compared to lignocaine. Please write a paragraph on this. No, this is not correct. You write a paragraph, you do a PubMed literature search, you write everything, you finalize your paragraph, cite them appropriately, and then can run the AI to see that whether grammars are okay or the language formatting is okay. AI is not adding or deleting any content or intellectual content of it. It is just checking the spellings.
Yes,
Thank
correct.
you. Thank you.
Rakesh sir, I refuse the preview of the articles every week. I refuse it. I get 1 or 2 emails every week that you preview or review that article. I said, no, I am not trained in it. I will not do it. I have written it specifically to some of them. I am not trained in it. I will not do it.
Thank you.
That's the language which I use, and it is true. It is
It's
true.
true, sir.
It's true. It's not my job, and I will not know the exact points where I have to review it exactly, isn't it?
So
So just
sometimes we send to senior people you because you may not be able to comment upon the core research or the idea, but sometimes we send it to the clinician also because we want to have their opinion from the clinic's point of view. So if somebody says this is better, then you can say, no, in my experience, this is better. So we can always reconsider whether the clinics or clinical experience is correlating with the research experience. So that's why clinicians are very important for even review. So that's the reason, sir.
hope I will
Sir.
accept it. If you say I will accept it
Sir,
next time, I don't
That's
know.
the reason, sir. That's the reason, sir.
And I was out
Yeah.
of touch all the time
Thank you,
because
sir.
I
Thank
was
you, sir.
out of India for
Yeah.
3 months. So I was out of touch.
Achha,
Now I
okay.
came back to again. I went to my daughter at London.
Oh,
So and I remembered Maya there also when I had gone and seen one of the place, and I had
Yes,
sent her
yes,
the photographs of one of the
yes, yes, sir.
1756 painter,
Yeah,
1756 from there.
correct, correct. Yes. So thank you for remembering me at London also, sir.
No, not that,
When you-
not that. When I had seen it, I could get it. Let us
yeah,
send it.
yeah, yeah. Thank you so much, sir.
Welcome, welcome,
So
welcome.
Rakesh sir, one question: what should be the minimum sample size which is accepted?
so there's nothing called minimum sample size. This is a calculated
Okay.
sample size. So it can be anything. So there's a way of calculating sample size based on the existing literature, based on the meaningful clinical difference, the alpha values, the power of the study. So there are certain parameters. Based on this, you have to calculate the sample size. So it has to be the same. For some study, it will be 500. For some, it will be 50. So there is nothing called minimum sample size.
Yeah.
I think if all the
think-
questions
Yes, our
are over,
questions are
madam.
over.
Sir,
After-
in
Oh,
ISACON,
thank
we
you,
should have
Bhavini
one
madam.
master
Thank you.
class or maybe one workshop on this, full day
Yes,
workshop, so that
absolutely.
all the queries and all the like whatever the doubts are there, that will be cleared. So I think we have in GARC also, no, master class
Yes.
on research methodology.
With I think every year around 4 to 5 workshops, 1 day workshop is being done. All are welcome
Correct.
to ISACON Raipur. So
Yeah.
The editor chief conducts pre-conference 1 day full workshop on research and
Workshop.
publications. So
Yeah,
anybody can join.
Correct.
Even GARC will also have.
Yes,
People
yes.
can take the
Yes.
opportunity. Absolutely.
Excellent, sir.
So much,
Excellent.
sir.
We are really so well enriched with your session. Thank you
Thank you,
so
ma'am.
much. Yes,
Thank you
thank
so
you.
much.
Thank you.
Thank you. In
Yeah.
case if
Now,
anybody still have question,
thank
feel free
you, Chaya
to
madam,
message me out.
Bhavini.
Thank you, sir.
Thank you,
Thank
ma'am.
you so much.
Thank you.
Our
I think-
secretary, Dr. Deshmukh Madam, will give us a vote of thanks.
Hello, everybody. Can you hear me?
Yes, ma'am.
Yeah, yes.
Mm,
Coming to
yeah.
the end of this webinar,
Yeah.
I'm so happy to hear from you, sir. And I wish to thank Dr. Rakesh Garg for accepting our invitation and being with us here today at such a short notice, sir. Sir, your talk has really opened different
Thank you.
doors to new horizons. And it has added a new perspective to our approach and our language, use of scientific language. I suddenly remembered that how many times I utter the word that I am reversing the patient. Thank you, sir, for being with us. I wish to thank SAMS for providing a technically perfect platform for the webinar. And I thank Ganesh also for being supportive all throughout. Our own people, Dr. Chaya Suryavanshi, for being a chairperson and adding useful summary tips, which will help us understand your talk, sir. And I thank Dr. Bhavini for flawless moderation of the session. I thank all the participants who make it a good success and for spending their valuable time with us. And with the permission of my committee, now I conclude this webinar. Thank you very much. Thank you
Thank
all
you, sir.
of you.
Yeah.
Yes.
It was nice meeting Deshpande sir also online. Thank you, Rakesh sir. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you, Rakesh, sir.
Thank you, Rakesh. See you again.
Thank
Yeah.
you. Thank you.
Bye.
Bye, everyone.
Bye.
Thank you for
Thank you,
Thank you, sir.
Deshpande, sir.
Everyone.
Good night, everybody.
Good
Thank
night.
you, sir, and good
Bye.
night.
Good night.
Thank you. Thank you.
Chaya and Bhavini, well done. Yeah.
Thank you.
Thank you.
Yes. Thank you. Bye-bye. Bye.
Bye-bye.